Okay, so we'll look at hypernatremia. Hypernatremia is simply defined as sodium concentration that is higher than 145 millimoles per liter. Now, some other texts define it as sodium concentration higher than 150 millimoles per liter. But generally around our locality here, we use 145 millimoles per liter. Hypernatremia can be classified based on volume status into hypovolemic hypernatremia, euvolemic hypernatremia, and hypervolemic hypernatremia. So we'll begin by looking at hypovolemic hypernatremia. Now, hypovolemic hypernatremia can be caused by maybe decrease in water consumption or increase in water loss with little or no loss of sodium. I said hypovolemic hypernatremia can be caused by a reduction in water consumption by the individual or an increase in water loss with little or no loss of sodium. So we'll look at both of them. Now let's begin with looking at increase in water consumption. Increase in water loss. Increase in water loss. Now this increase in water loss can be extrarenal or renal fluid loss. Increase in water loss that causes hypernatremia, that is hypovolemic hypernatremia, can be either due to increase in renal loss or increase in non-renal loss, or can be due to renal loss or extrarenal loss. So let's begin by looking at extrarenal loss. Now, extrarenal loss of fluid can be caused by situations such as increased sweating or excessive vomiting or severe diarrhea or burns, maybe fire burns, or um, maybe sodium retention, maybe due to sodium retention, right? Remember that we're looking at hypovolemic hypernatremia. So now, these situations can result in loss of fluid with retention of sodium. So that means somebody is sweating excessively, is not losing so much of sodium, but is losing a lot of fluid. Somebody may be vomiting, and in that vomit, there is sodium retention. Is not losing sodium so much, but is losing a lot of fluid. Somebody can also be stooling so much and is not losing sodium so much, but is losing a lot of fluid. And then also due to burns. Now in burns too, the person may not be losing sodium so much, but is losing a lot of fluid, right? Whichever condition, or is it dehydration? The individual is dehydrated, and so now all these ones are extrarenal losses. It doesn't have to do with the kidney. And with these losses, fluid is lost massively and sodium is being retained. So in that situation, remember that when we measure sodium against a given volume. So in that situation, with all these conditions that we have mentioned recently earlier, in that situation, you measure sodium. Sodium concentration will be high because you are measuring sodium against volume. Now, there's excessive loss of volume with sodium retention. Any situation that results in excessive extrarenal loss of volume with sodium retention, when you measure sodium, you will see that sodium concentration will be high, and um, because there's a loss of volume, because you are measuring sodium against a given volume. Then we look at renal losses. Now, renal losses can be caused by the use of diuretic medication. The use of diuretic medication. Now, in the use of diuretic medication, diuretic medication, what it does is that it prevents the reabsorption of fluid or of water from the glomerular filtrate. So, in use of diuretics, sodium is reabsorbed, right? And so when sodium is rea- is sodium reabsorption is not hindered, but water loss is facilitated. So in that situation, the individual is losing fluid, yet is retaining sodium. When you measure sodium in that individual, those sodium concentration will be high because remember, you are measuring sodium against water volume. And so this one can be caused, like we said, by use of diuretic medication. It can be caused by kidney disease. It can be caused by kidney disease. Probably the kidney is allowing sodium to be retained, maybe the renal tubule, but is not allowing water to be reabsorbed. Maybe the renal tubule is not allowing water reabsorption, but is still sodium reabsorption is still taking place. That results in hypovolemic hypernatremia. Then also diabetes insipidus. Diabetes insipidus is another condition that can cause hypovolemic hypernatremia because in diabetes insipidus, there's excessive water loss, but the solutes are not being lost. Remember that we said that there is the loss of solute-free water. So solute is being reabsorbed, the electrolytes are being reabsorbed, but sodium is not also being reabsorbed. Sodium is lost excessively, and that can cause hypovolemic hypernatremia. So in to distinguish between renal losses and non-renal losses of sodium, if you measure sodium concentration in the urine of individuals that are suffering from extrarenal losses of fluid, if you measure sodium concentration in those individuals in their urine, sodium concentration will be less than 10 millimoles per liter. However, in individuals that are suffering from renal loss of fluid, that are having hypovolemic hypernatremia due to renal loss of fluid, when you measure sodium concentration in their urine, sodium concentration will be higher than 20 millimoles per liter. So you see that there'll be a lot of sodium in people with renal losses. Why? Because some amount of sodium is also following the water as the water is coming out of the kidney. So you see that you measure the urine, there is still sodium being lost, but more water is lost compared to sodium. But in individuals with extrarenal loss, sodium is coming out through the urine, but it's not high. It's not high. It's low sodium. So sodium concentration in urine will be less than 10. But those with renal losses, sodium concentration in urine will be greater than 20 millimoles per liter. So now we look at decreased water consumption. Now, decreased water consumption can be caused by maybe dementia. It can be caused by dementia. The person cannot even remember whether he needs to drink water or not. He's thirsty, but he cannot remember whether he needs to drink water because of dementia. And then severe depression. Maybe an individual is depressed, and depression is like a psychological or psychiatric condition. The person is depressed, so even if he's thirsty, it's not that is not that is not the person's problem. It's not even reasoning about thirst at all. So in depression, there can be decreased consumption of water. Then in psychiatric cases, individuals with psychiatric or mental disorder, a mad person doesn't even know whether there's difference between being thirsty and not being thirsty, so he doesn't drink water, right? Then another thing that can cause a decreased consumption is when a patient is sedated and is not placed on drip. That person is on sedative, he's sleeping, even though he's thirsty, because he's sleeping, he doesn't even, water is not, drinking of water is not, it doesn't come up at that point because the person is on sedative and is sleeping. And then though also when there's a brain disorder that has affected the test center or affected affecting the test center, the person cannot even know whether it's testy or not as a result of a disorder in the brain, or maybe maybe a brain damage that has also affected the production of antidiuretic hormone, for example in Parkinson's disease or people with brain tumor. Now these ones don't even, the ADH production is affected, and so because of that there's excessive loss of antidiuretic hormone. So these are conditions that are associated with decreased water consumption that can cause hypovolemic hyponatremia. Hypovolemic hypernatremia, sorry. Hypovolemic hypernatremia.